So some people will go straight into the workforce. And I'm sure as parents, you're excited for your kids to become independent and actually have an income and not kind of feed off of your income. But oftentimes in work, there's also a lot of variable hours. And what happens when I get sick? What happens if my performance suffers because something is just happening because of my diabetes? So Title I of the ADA actually protects you in this setting. The ADA makes it unlawful to discriminate in all employment practices, such as recruitment, pay, hiring, firing, promotions, job assignments, training, leave, layoff, and benefits. It's really to say that, hey, you are a fully functional person. If something happens with my pancreas, I'm not going to get affected. And this also ensures that there's reasonable accommodation. Now again, most of the workforces out there will just do this just because they're a team player. I work at UCSF, and really any kind of these accommodations we don't really have to do formally. Some work environments are different. So again, I'm just saying these, telling you about these laws in the case that you have a job that may not be as accommodating. So reasonable accommodation is any change or adjustment to a job or work environment that permits a qualified applicant or employee with disability to participate in the job application process, to perform the essential functions of a job, or to enjoy benefits and privileges of employment equal to those enjoyed by employees without disabilities. For example, reasonable accommodations may include acquiring or modifying equipment or devices. In this case, it may be just a refrigerator on site for insulin. Job restructuring. Again, it may be that you just need breaks. You can't do an off-field site for 8 hours straight without having the ability to check your blood sugar or eat. Part-time or modified work schedules, reassignments to vacant positions, adjusting or modifying examinations, training materials or policies, providing readers and interpreters, and making the workplace readily accessible to use. And one of the biggest things that people struggle with is, should I ever tell my boss? Your condition is your condition. So this is from the Equal Employment Opportunities Commission, and I have the website link below, and this is from the federal government stance. And the question was from an employer. Am I obligated to provide a reasonable accommodation for an individual if I'm unaware of her physical or mental impairment? The answer is no. An employer's obligation to provide reasonable accommodation applies only to known physical or mental limitations. However, this does not mean that an applicant or employee must always inform you of a disability. For instance, if the disability is obvious, in this particular scenario, it's an applicant who uses a wheelchair, but if you have a glucometer out and you're checking your blood sugars, that's a little obvious. How do I let my boss know? And as an adult practitioner, this actually comes across for many people with different health conditions that may affect their work. So oftentimes, I don't have to disclose anything. I can write a note to my patient, and actually I work with them on the wording, depending on their boss. And oftentimes I'll write something like, "Dear employer, Mr. Smith requires the ability to take a 15-minute break periodically because of their health condition." And oftentimes I have to work closely with my patient to go ahead and write something that I don't disclose medical conditions, but still allow them accommodations at work. Some workplaces still require disclosure of the actual illness. And again, people work with it differently. But again, if you do need some accommodation, you may have to work with your doctor and your employer to meet your needs. So switching gears a little bit, so that was kind of the vocational and the work setting. We also have to think about healthcare, because as we get older, we start changing the people that we see. So one of the things that we have to talk about is the fact that your relationship with your parents will change. So and we also think about future planning. So this cartoon, for those who can't read it, by 2018 you will have left home and no longer be a financial burden on us, and that's our 10-year plan. And rightly so. But there's a couple of other changes that affect sort of the parent and child relationship. And the step from 17 to 18 is one small step or a day for a person, but it's really one giant leap for expectations. A child who's 18 is now a legal adult. That doesn't mean you act like an adult, but there are different ways that we have to deal with a patient. Moreover, if I say something to a 17-year-old, I can bring my force my decision, with the parent there advocating for that. But once they turn 18, I have to get agreement from the patient. The medical establishment now must abide by a different set of laws and regulations. The physicians must meet confidentiality standards. And again, these kids no longer require parental consent unless the parent is a conservator. And that changes a lot of the dynamic between the adult medicine world and the pediatric medicine world. So moving from pediatric to adult focused care, again, we're all getting older. And your pediatrician will not be able to care for you indefinitely. And this means eventually finding a new healthcare team in the future. And why is transition preparedness important? Well, most youth have been in pediatrics and are now beyond the expertise of pediatrics specialists. Young adults often have not been really fully prepared to tackle an adult healthcare system. Most of the time, your parents, you've been out there on the phone, calling, getting scheduled, going around a lot of loopholes. And oftentimes the kids are sort of spared from that, and suddenly they're being expected to take on a lot of this responsibility. And also, the adult healthcare system is often not prepared to work with families jointly in caring for young adults. Where pediatrics, it's always been kind of parent and then child, but in the adult system, it's really just the patient and the doctor. And so there's differing philosophical differences between pediatrics and adult medicine. For instance, in pediatrics, a lot of parental involvement. I mean, really, you have to give informed consent. You know everything. We'll tell you how many diapers your child, had. We don't necessarily do that for the adult. In adult medicine, it's a lot about patient autonomy. In pediatrics, we often have multi-subspecialty clinics where you have a lot of different subspecialists within one. In the adult medicine world, it's oftentimes a primary care provider and your child or your patient working with subspecialty on a consultation basis. Pediatrics is very family-oriented, whereas adult medicine is very patient-focused. In pediatrics, we have different types of child programs. In the adult medicine world, we have different types of insurance programs, and that will change drastically after between 18 and 26, depending on which category you're in. In pediatrics, we focus on child life in school, and in adult medicine, we focus on adult productivity. Pediatrics is filled with rare diseases started at birth, and whereas in adult medicine, we're oftentimes focused on acquired diseases. And really, we're kind of warm and fuzzy in pediatrics. In fact, I have a different white coat and one with little animal buttons. I have to take that off when I'm in my adult medicine clinic. They look at me kind of funny. So when we think about the adult world, again, about the issue of confidentiality, because again, your child or the young adult is now our patient, we oftentimes think about privacy. And why does that even matter? Because in a hospital, we have to go by the Health Insurance Board Building Accountability Act. And oftentimes we say, don't make a slip-up with HIPAA, because there's actually a sign that was posted when I was a resident. And it was meant to protect individual rights so we don't disclose information to people who shouldn't see it. But this sometimes gets away with parents because, well, I take care of my child, I'm paying for their insurance, I know they're 19 or 20, but I really need to know. And why is that, an internal medicine doctor refusing to share information with me? Well, it's not because we're jerks. It's really not. It's really trying to say, well, we need to get permission first and then disclose. And so there's a lot of ways to work with the healthcare system, but just knowing that it's a little bit of an extra step, but it doesn't mean that you can't get information about your child. So the privacy rule is a federal law. It gives you rights over your health information, sets rules and limits on who can look at and receive your health information. The privacy refers to all forms of individual protected health information, whether it be electronic, written, or oral. When you're in clinic with your child, addressing for the parents, you give tacit agreement, that is, your child does. The very fact that your child invites you into the room is tacit agreement that we can share information. In fact, based on the law, it's whether or not the child objects for you to be in the room or not. That being said, providers vary in terms of privacy. Some are more formal in terms of permissions for sharing information and ask for privacy. So they'll ask for a HIPAA release form so that the child will sign it and say, yes, I'm going to say, my mom, my dad, these are the people you can share information at any time, whether they call, electronic, data sharing, etc. Because doctors are not technically supposed to share information about health unless permission is granted. And adult physicians are much more protective of patient confidentiality because, quite frankly, there's a lot more people involved in their lives. There's employers, significant others, co-workers, workforce. We don't know who's on the other end of that phone when you call. Whereas a pediatrician's office, usually it is the parent and you've known each other for a long time. So that's sort of like a little bit of a shock that parents go through as the child transfers. Just a little bit about insurance, because there's a lot of changes going on nationally. Many people are covered under various different insurance plans, whether it be the state child health programs, your employer-based insurance, CCS, Medicaid. A few of you may be on Medicare. Oftentimes there are also state programs and county-based programs. And eligibility requirements change fairly abruptly. So in maintaining insurance, the nice thing is about the 2010 Patient Protection Affordability Act has extended for those under private insurance to covered in the parent plan up to age 26. This will be mirrored in Medicaid in 2014, which makes a huge boon for young adults who are going to college, early work. They may not have employer-based insurance, but they can get covered. Keeping enrollment into Medicaid for those on Medicaid is not necessarily automatic. And so you have to think about by age 19 or 21, again, depending on what your plan is, to kind of work with your social worker, your financial planner, the CCS worker, to ensure that that continuity exists. I cannot tell you enough, as an adult provider, how many people I see who end up being disenrolled, not continue. And I mean, one story was a 19-year-old who just turned 19, would qualify for Medicaid, and needed an MRI because she was decompensating. And UCSF doesn't give retroactive Medicaid, so I had to, luckily, in the state of California, we do have the safety net hospitals that will allow you to put in an application, and if you qualify, whatever services that you had that day will be covered once that application is approved. That's called retroactive Medicaid, and that is done at the public safety net hospital. So just know that there are ways to ensure that there's coverage even during emergencies. And again, each state has different enrollment criteria and programs available, and if people have questions, we can talk about that offline. So how do we sort of prepare for this milieu? And one of the biggest advocates is you, both the patients and the parents. You can talk about this with your endocrinologist, your primary health care team. Just thinking about the future, it's good to start early talking about, well, at what age, I'm thinking about college, I'm thinking about work, I may be going away. What's my plan? The community service agencies here are remarkable, and they oftentimes will give support in many avenues. There's, JDRF, there's the Disability Rights Education Defense Fund, support for families. JDS works in vocation, so, and if there are issues about work and, well, how do I disclose my disease process or get accommodation, these are agencies that are very helpful in helping people along, and also legal services in the case that you hit a stumbling block. Insurance companies also oftentimes will help families facilitate transfer, especially once you're hitting an age of aging out of a certain insurance bracket. And also the Title V agencies, or CCS, do have transition programs as well. Other things that are available, there are checklists that are available online. I have one I can give. There's a whole slew of these. If parents want to know, well, what should I be doing as a parent to sort of kind of help my child prepare? And if there are differing recommendations that are out there, and really whatever fits your particular need. So thank you, and if you have any questions,